Welcome. I hope everyone is doing well. So glad that you're here. I want to be very quick in my remarks because we have so much interesting information to get to and our wonderful speaker. I do want to thank the School for Professional Studies staff who's here with us and supporting us and who's made this possible. I want to thank the Center for Medical Ethics at CUMC as well. And I definitely want to thank my colleagues in the Masters of Bioethics program for supporting this. And I especially want to thank my partner in crime for this series, Lydia Dugdale, who I think shares my belief that ethics can be a place to catalyze positive change in equity and justice and protection for the vulnerable. And the best place to look for those opportunities are places that make us uncomfortable. So here we are today. A year ago, I just wanted to give a quick 30-second story about what got us here. A colleague told me a story about seeing a patient in the emergency room, someone who had been treated chronically with opioids for a while, and suddenly now is being told, no, we're not giving those to you anymore, but with no alternative to the chronic pain syndrome that he had, whatever that be, physical or psychic, no alternative, just we don't do that anymore. And my colleague said, aren't we abandoning these patients? What is happening? Just because the pendulum has swung, that doesn't mean people still don't experience pain, still don't have addiction problems, still don't have whatever it is that brought him to us in the first place. Do we not have an obligation to continue to care for this patient? And it got us thinking about what that really means and whether medicine has taken a long, hard look at our role in the current opioid crisis and what we could do to make it better. So along those lines, we are so lucky to have a national expert with us today, someone who truly has thought about this in a way and has contributed to a lot of positive change, is Dr. Sarah Wakeman. She is the medical director for the Massachusetts General Hospital Substance Use Disorder Initiative Program and an associate professor of medicine at Harvard Medical School. I have read her work, her research, and a lot of her essays, and she is just, I aspire to be her in my next life. So we're really excited to have her. And you can, I just wanted, before we go, say that you can put your questions in the YouTube in the chat, and we will be taking questions at the end. My colleague Samir Lada, my wonderful colleague from Bioethics, will be helping you out there in the chat. Okay.
Wonderful. Thanks so much for having me. I think you guys will share my slides. I'll wait for that for a moment. Fabulous. So thanks everyone for joining, and thanks so much for the invitation and that wonderful framing of the sort of nuances of thinking about what's called the opioid crisis. I prefer calling it the overdose crisis now, and I'll talk about why. And today I hope I'll frame for you guys an understanding of the overdose crisis, sort of where we've been and where we are, and how we can think about equitable and ethical systems of care. Oh, next slide, please. My disclosures, I do some scientific advising for a company looking at interventions to reverse overdose. I had a research grant with Optum Labs, and I'm a reviewer for UpToDate, which is a medical online journal. Next slide. So I think living in this country, you're probably aware that pre-COVID, we were also in the midst of an ongoing public health crisis. The overdose crisis, which has now claimed more than 750,000 lives since the onset in 1999. Last year was the highest year yet on record, with 72,000 people dying from drug overdose. And that has surpassed the peak number of deaths from HIV/AIDS at the peak of the HIV epidemic, from motor vehicle accidents, and from firearms. So when people use words like crisis and epidemic, the reason for that language is really the toll that this has had, to the point that actually, again, prior to COVID-19, the impact of the drug overdose crisis had led to a 3-year decline in US life expectancy, which is the first time we'd seen that since the 1918 influenza pandemic. And when we think about the overdose crisis, I really think of this as a crisis due to inadequate care and treatment. And one thing that makes it so devastating is really no one should die from a drug overdose. We know how to intervene in the moment of an overdose and keep someone alive. We know about public health interventions and strategies to prevent people from experiencing an overdose and dying from an overdose in the first place. And importantly, for those folks who have an underlying substance use disorder, particularly opioid use disorder, we have highly effective treatments that increase people's likelihood of remission and keep them alive. And so this is really a crisis of access, of being able to access those public health interventions and treatment. And as I'll talk about this afternoon, one of the driving reasons for that is really stigma and bias, and unfortunately a mismatch between ideology related to drug use and addiction, and how we actually approach these issues as a society. Next slide. And so, although this has been an ongoing crisis for more than a decade now, we unfortunately are seeing that COVID is having a negative impact on overdose as well, with preliminary data suggesting that both non-fatal and fatal overdose are increasing amidst COVID-19 since the lockdown. And this really comes as no surprise when you think about drug use and addiction, social isolation, loss of economic opportunity, despair, all of the things that everyone is struggling with in the midst of this global pandemic are particularly challenging when someone has a substance use disorder and is at risk for overdose. And then obviously access to treatment and resources as well. So the crisis of overdose deaths has been with us and been ever pressing, and seems like it will only get more so as we move forward in the post-COVID times. Next slide. When we think about responses, Barbara already mentioned the focus on opioid prescribing, and in fact, that's where a lot of the national attention and the attention within the healthcare realm has focused. And that has to do with the fact that when we look at the onset of the current crisis, which again began around 1999, we saw a correlation between changes in opioid prescribing with a pretty dramatic increase in opioid pain reliever sales, and correlating along with that were deaths due to opioid pain relievers and treatment admissions for opioid use disorder. And that narrative of the sort of prescription opioid crisis has been well told in the lay press and in the medical literature, and obviously we see that play out with lawsuits against pharmaceutical companies related to opioid prescribing. Next slide. But in fact, the attention and interventions around opioid prescribing have had an impact on prescribing, and we could talk extensively about whether that impact has been good or bad, or how it has made a difference, and the ethics associated with that, particularly for people who have chronic pain and have been on chronic opioid therapy. But regardless, when we look across the country, the peak number of opioid prescriptions happened in 2012, and every year since then, we've seen a decline in opioid prescriptions and deaths due to opioid prescribing. And so really the only thing we needed to do to address this crisis was to target opioid prescribing, which has been a lot of the narrative, that we need to go after doctors and go after pharmaceutical companies. Then we really should have declared victory of the overdose crisis. That as we've seen this decline in opioid prescribing and deaths due to opioid pain relievers, we would expect that the overdose crisis would be getting better. And yet if you saw that line, we've instead seen the opposite. We've seen it continue to get worse, and in fact the rate of increase of death increased. Next slide. The challenge with focusing exclusively on opioid prescribing or blunt policies, which unfortunately policies related to medicine often end up being quite blunt, is that they are quite problematic and probably are not targeting the areas that we want to. So when we think about how can we reduce the supply side of the equation of this and hopefully prevent people from developing an opioid use disorder and ultimately being at risk of dying from an overdose, you would think that we'd want to not use opioids for people who have mild pain, who probably don't need an opioid, that we would really try to change prescribing practices so that we're only using opioids as medications for people with severe pain that's really not responsive to other interventions. And yet what we've actually seen is the opposite, that although we've seen a decline overall in opioid prescribing, the group that has had the greatest decline are those patients like Barbara described, the individual showing up in the emergency room. They're people who actually have moderate to severe pain, who've been living with chronic pain. Those are the patients who've been experienced the biggest decline in terms of opioid prescribing, as opposed to people with mild pain who probably never needed an opioid in the first place. And the other problem is that we know racism is at play in healthcare broadly, but particularly in the realm of opioid prescribing and pain relief. It's been well documented, the impact of racism on decisions around treating pain. And unfortunately, we're seeing that also in opioid prescribing reductions, where the largest reduction in opioid prescribing occurred amongst Black adults and people already living in poverty. Next slide. I mentioned this about racism. Racism obviously impacts all of healthcare, it impacts our society at large and the risk of dying in a racist society. And yet pain management is one of those areas where there's actually been a fair amount of research of the impact of provider bias and belief, racism on the provider's part, translating into clinical care and outcomes. This was a really concerning study not that long ago, 2016. It was a study of 222 white medical students and residents, so those are doctors in training, that found that 50% of them endorsed at least one false belief about biological differences between Blacks and whites. So things like Black patients' skin was thicker or their nerve endings were less sensitive. And that those students and residents who endorsed those false beliefs were more likely to say that they didn't think a hypothetical Black patient described in a clinical scenario was experiencing pain. So racism is clearly apparent when we think about pain management and opioid prescribing. Next slide. The other reason why targeting just opioid prescribing is nuanced and perhaps not leading to the outcomes that we want is that studies that have looked at what happens when doctors decide to stop prescribing to people who've been on high dose chronic opioids have actually shown that overdose is more common after discontinuation of chronic opioids. So again, if the thing we're trying to prevent is people dying, not necessarily a certain number or meeting a certain policy target, then it doesn't seem like necessarily this kind of blunt singular focus on prescribing is the solution to addressing the ongoing overdose crisis. Next slide. In addition, the reason why focusing just on prescribing has been unhelpful is that what we see instead is the shifting use patterns as you shift the supply. So if you think instead about the overdose crisis being a crisis first of despair and a broader sort of testament to what's going on in our society at large, but also an issue of people who have the illness of opioid use disorder who are unable to stop using opioids. And all you do is you make it harder for them to access a certain type of opioid, prescription opioids. What we see predictably, and this has been shown in qualitative work and quantitative work, is a shift from people using prescription opioids to people using illicit opioids, so opioids in the illicit drug supply. On the left here, you'll see a graph. This is a study of thousands of people entering treatment for opioid use disorder and asking them what was the first opioid that they used. And you can see that as OxyContin, which is the extended release formulation of oxycodone, a powerful pain reliever that's very much been in the news because it's made by Purdue Pharmaceutical, which recently settled a huge lawsuit. It was reformulated in 2010 to be less able to crush it and use it by either snorting or injection. And we saw this pretty rapid shift, actually, that people stopped using it. They shifted into heroin. And we've also seen this in studies, for example, this paper in the New England Journal of Medicine, which showed that as prescription opioids became harder to access because they were being prescribed less, their cost on the street goes up, they're less accessible, people shift into heroin and deaths due to heroin increase. Next slide. And so this gets at the nuance of the supply and demand drivers of the overdose crisis. So for sure, there are supply side drivers, and excessive opioid prescribing was one of those supply side drivers without a doubt. There are also changes in the drug supply. So highly refined Mexican sourced heroin, and then now more recently, synthetic opioids like fentanyl adulterating the supply have all played a role in thinking about the overdose crisis. But there are also demand side drivers. Demand for prescription opioids drove the demand for heroin as substitute as prescription opioids were harder to access. And demand for heroin then feeds in part demand for fentanyl as substitute now that the illicit drug supply has changed. When we think about what it is that's actually killing people at this much more rapid pace in the last few years, it's really poisoning of the drug supply. It's the unpredictability of the drug supply with contamination with illicitly manufactured fentanyl. And in fact, there's been some arguments that focusing just on supply, so for example, making it harder to access prescription opioids or cracking down on the enforcement side of the illicit drug supply can actually cause paradoxical and unintended harms. And this has been termed the iron law of prohibition. Next slide. So this gives you a sort of broad schematic of what is the iron law of prohibition. This term came out of prohibition for alcohol, where what was seen across the country was that once prohibition was put in place, there was a transition from most Americans who drank lower alcohol by volume beverages like beer and wine. And with prohibition, there was a transition to spirits and then ultimately to moonshine. And what people see is that as you increase law enforcement and you increase the cost and the risk of the now what has become an illegal process of selling alcohol, for example, and the need to avoid detection, you actually put pressure on the system so that those who are making and selling the substance have an incentive to come up with something that has less weight and volume, is easier to hide, where there's a higher return on investment, easier to store and transport, so more potent substances, and then ultimately more harmful substances with changes in the supply. So what we're seeing with the opioid supply is really this transition from prescription opioids to heroin, and then increasingly now to illicitly manufactured fentanyl, which is much more potent, easier to manufacture, and again, that sort of squeezing balloon with iron law prohibition. Next slide. And so the CDC now talks about these three waves of the opioid overdose crisis. So the first wave, again, was prescription opioid overdose deaths, which we saw increase beginning in 1999, and then peaking around 2011, 2012. And yet, instead of seeing lives saved, what we saw was this transition first to heroin, with a rapid rise in heroin-related overdose deaths beginning in 2010. And then really the current wave of the crisis was beginning in 2013, where there's this dramatic shift in the illicit drug supply, with this poisoning of the illicit drug supply and the introduction of fentanyl contaminated heroin and illicitly manufactured fentanyl analogs, which added in this whole level of unpredictability and greater risk of death and harm for people who use drugs. Next slide. So the evolution of the drug overdose epidemic, opioids continue to be the driver, but it's really not just an opioid crisis. It is a polysubstance crisis, and people who use all substances are affected. So opioids are involved in about 2/3 of overdose deaths. Illicitly manufactured fentanyl is the thing that is driving overdose and fatality, and that's important because the interventions that we know work really target opioid-related death. And we've seen heroin and prescription opioid-related deaths decrease and or remain stable. With this evolution of the polysubstance crisis and really a drug overdose crisis, we've been seeing rising rates of overdose deaths from cocaine and stimulants. It's not just about opioids. And importantly, despite the whitewashing of the narrative in the lay press and in the medical literature, this idea of talking really about the opioid crisis as a white person's problem, the magnitude of change in overdose deaths and opioid-related deaths is greatest amongst Black Americans. So you can see up top this sort of representative circles in terms of the magnitude of increase. There's been an 18-fold increase in overdose deaths involving synthetic opioids, which really is fentanyl, amongst non-Hispanic Black Americans, a 12-fold increase amongst Latinx, and a 9-fold increase amongst non-Hispanic whites. So although the media attention, much like many things, focuses on the toll amongst white people, really the toll amongst Black and Latinx communities has been dramatic. Next slide. And this gets to one of the many deep challenges as we think about responses to the overdose crisis, is the fact that our entire structure of drug policy is rooted in racism. Our country's drug policy has always been about racism, going back to the early 1900s. This is an article in the New York Times, the paper of record. You can read the title for yourself, but this fear mongering related to racism, infused with racism, really drove the laws that began in the early 1900s that still dictate how we can treat people who use drugs, what doctors are allowed to prescribe in terms of addiction, and our drug laws as they relate to mass incarceration and the criminalization of drug use, particularly when it happens amongst Black and Latinx individuals. We see this play out with people of color experiencing discrimination at every stage of the criminal legal system. Black and Latinx individuals are more likely to be stopped, searched, arrested, convicted, and harshly sentenced for drug law violations. And the majority of people in federal and state prison for drug offenses are Black or Latinx. So although we're now having this narrative of sort of a gentler public health approach to the overdose crisis, the reason for that really is racism, that now that there's this sense that, even though not really backed by data, as I showed you, but the narrative has been that this impacts white people dramatically. Now we're talking about this as a health issue and as people needing treatment and needing to think about care rather than punishment. But in past drug crises, when Black and Latinx communities are affected, and even now, when those communities are affected in the midst of the current overdose crisis, the response has been one of punishment, of mass incarceration, and really taking dramatic tolls on communities. Next slide. This is particularly relevant as we think about the growing attention to racism, which of course has been with our country since its founding, and where the death of many Black Americans at the hands of police have been directly or indirectly related to the war on drugs. You think about Breonna Taylor, who was killed in her own apartment because of a no-knock warrant and concerns around drug use and really our failed drug policy. George Floyd, as he was strangled and suffocated with an officer's knee on his neck, one of the officers standing by said to the crowd, "Kids, this is why you don't do drugs." So as we think about racism and our growing societal awareness long overdue to the toll of racism and the fact of police killings of Black people in this country. The war on drugs is intimately intertwined with that. Next slide. The other thing is that overdose, which of course is the thing that we're trying to address when we think about talking about the overdose crisis, absolutely does discriminate. And those who are at greatest risk of death are often those who are already most marginalized in society. So here in Massachusetts, the people who are at greatest risk of dying from an opioid-related overdose are people who've experienced homelessness, people who've experienced incarceration, people with serious mental illness, and pregnant and parenting women in the postpartum period. The populations who are already vulnerable and often who are not in mind when we think about the design of our treatment system, which makes it really, really hard for anyone to access treatment and certainly hard for people who are most marginalized from care. Next slide. As I touched on earlier, the overdose crisis in Black communities continues to grow, and yet this public attention is really focused on the impact on white people. And yet in some states, opioid overdose death rates amongst Black Americans actually exceeds the general population and the white population. And yet our approach, again, for Black and Latinx individuals who've been suffering from opioid use disorder has been heavily criminalized instead of focused on treatment and prevention interventions. Next slide. Racism, of course, plays out in incarceration across our country. This is a slide showing states that have a Black-white differential or a Latinx-white differential. And so you can see the darker the state, the greater the differential. So here in the Northeast, particularly with Latinx and white differential, we are doing very poorly when it comes to the impact of racism on incarceration. And you can see everywhere that there's a massive Black-white differential as well when it comes to incarceration. And this is largely driven because of the war on drugs. Next slide. We also see this play out not just in systems that are designed to be carceral systems like the criminal legal system, but also in systems that on their surface are designed and or talked about as if they are systems of support. And yet really, if you dig beneath the surface, they also have carcerality to their design and certainly to their impact, and the impact on Black and Latinx women and Indigenous women who use drugs is dramatic in the child welfare system. And this is a wonderful report by the Movement for Family Power that says, it's not a coincidence that the overwhelming majority of parents involved with the foster system are living in poverty, or that Black, American Indian, Latinx parents are overrepresented. Nor is it a coincidence that the foster system is designed to protect children from one type of harm only, harm from their parents. The foster system has been instrumental in demarcating the, quote, undeserving poor and perpetuating the myth of racial inferiority. It has provided fertile soil for entrenching the idea that people of low incomes and our racial minorities are responsible for their social problems. If parents are to blame for their poverty, for example, then they are the cause of the harm that befalls children as a result of their poverty. And allegations of parental drug use have become a smokescreen behind which this injustice plays out. You can see here the racial differential in terms of loss of custody, with 1 in 9 Black children removed from their parents' custody between 2000 and 2011. Next slide. This impact of custody loss on women and children, particularly when we think about the context of substance use disorder, is dramatic and harmful. Substance use is the main reason for child welfare involvement. We know that Black communities already experience intense social surveillance and are more likely to be reported to child welfare authorities at all levels. And research on the impact of this, both on children and on the mother, it has been shown that it's overwhelmingly negative, that the long-term outcomes are negative both for mom and child. And for women in particular, Black women and poor women who use drugs, the psychological toll, the emotions of guilt, bitterness, anger, feelings of failure as a parent, and his helplessness are dramatic and traumatizing. Next slide. Another way that we see racism impact the way we talk about and think about drugs is a lot of the myths around drug use. So I'm going to next shift to talking really about opioid use disorder, or the illness of addiction, and what are strategies that have been shown to be effective to treat it. But it's really important to note that most people who use drugs never develop addiction. I think we don't talk about that enough. We spend a lot of time in medicine or in society talking about the harms of drugs, and yet many of the harms, maybe most of the harms that people experience who use drugs, are actually harms of prohibition. They're harms of our drug policy. So for example, people don't get life-threatening infections. People who inject drugs don't get life-threatening infections from the drugs. They get them because we criminalize drug use, and because people are using in unsanitary conditions, and they're using alone, and they're having to rush their use because they're worried about getting arrested or getting incarcerated. People die from overdose, again, because they're using in unsafe settings, they're using an unpredictable and dangerous supply because we don't have compassionate and thoughtful harm reduction and treatment services. This is a powerful piece by Carl Hart, who I'm sure you all know well at Columbia, really worth a read about how exaggerating the harmful drug effects on the brain is killing Black people. And there are many harms to thinking that any drug use leads to addiction, but in particular, when we think about police killings of Black people, it's crucial to note that we don't overstate the role that addiction plays amongst people who use drugs. Next slide. So when we think about our practice and policy, despite the fact that, as I'll talk about next, we have decades of science showing us what are effective treatments to treat addiction and what are effective interventions to reduce the risk of death or harm, much of what happens in the clinical setting and at the policy setting really has no relationship to what we know from evidence. There's this vast chasm between kind of the evidence and science and research and then what actually happens in the policy and clinical practice arena. And this was an interview with Dr. Dole, who is the physician scientist who discovered methadone as a treatment for opioid use disorder. And he highlights, that he kind of stumbled into addiction medicine. And the thing that was most educational for him was really recognizing that the stigma, the biases that he brought to that as just a member of society, the biases that we're all influenced by, were completely wrong. And yet those notions that people who use drugs are dangerous, that they're not to be trusted, that they're unreliable or weak, continue to influence our drug policy and the structure and design of our treatment system. Next slide. So we think about effective components of treatment, particularly for opioid use disorder. And again, just talking broadly about the opioid-related overdose crisis, I'm going to focus on opioid use disorder. It's really a range of interventions, much like many other chronic illnesses, where medication is a cornerstone and is actually the most effective treatment we have for opioid use disorder. Psychosocial interventions are crucial and should be available, but not required. Recovery support, so how do you really support the human being and the fabric of their lives as they navigate engaging in treatment, which is true for any chronic illness. And then harm reductions. How do you reduce the negative consequences of untreated illness, which is something we think about across the board in the rest of medical care at the same time that we do treatment. We don't think of those things as separate and really need to not think of those things as separate when we talk about addiction treatment either. Next slide. So the first point is that medication saves lives. So we have highly effective medication to reduce the toll of the overdose crisis. So unlike COVID, for example, where we're waiting for effective breakthroughs in terms of medications and vaccine therapy, we actually know what works when it comes to saving lives with medications from opioid use disorder. And so the issue has really been the barriers to access and the ways that we've chosen to regulate and limit access to these life-saving medications. In contrast, when France was in the midst of their own heroin overdose crisis, they took a very different approach where they allowed all doctors across the country to prescribe buprenorphine, which is one of the medications we have that has been shown to be highly effective for opioid use disorder. Unlike here, where you have to go through 8 hours of additional training on top of your usual medical training, you have to get a special license from the DEA. There's all sorts of requirements on how many patients you can treat and what you have to offer them. In France, they just allow doctors to offer this the same way they offer any other treatment. And what they were able to do is get actually 90,000 patients treated. Overall, they had 2/3 of their population that had an opioid use disorder got on therapy. And they saw a 5-fold reduction in heroin overdose deaths, a 6-fold reduction in active injection drug use, and a dramatic decrease in HIV amongst people who inject drugs. So these medications work. If you let people access them, they save lives. Next slide. Again, I could do a whole talk just on the data on each of these treatments. There have been decades and decades of study looking at these treatments, but medication treatment with methadone and buprenorphine, which are the two most effective medications we have for opioid use disorder, dramatically reduce mortality, both all-cause mortality and overdose-specific mortality. And when people are in treatment, they're much less likely to die. If they stop treatment, that risk increases. Next slide. And importantly, not all treatment pathways are equally effective, although there's lots of sort of popular sayings in the addiction treatment world, one of which is sort of multiple pathways. In fact, although there are many, many different pathways that are offered for treatment for addiction, they're not all equally effective. And so that false equivalence is really harmful because I think patients don't often know the research and the information as they're making decisions. And certainly their family members and their support networks often don't know that. So informed decision-making is crucial. This, for example, was an early randomized controlled trial looking at buprenorphine, which is one of those medications I intervention that's effective for opioid use disorder treatment versus people going to detox, which is where sort of the withdrawal symptoms are managed, but they're not kept on medication, and then being connected to a year of intensive counseling. The group that went to detox and had a year of intensive counseling, no one stayed in treatment. 100% of people had recurrence of active use, and 20% were dead at the end of 1 year. In contrast, the group that was prescribed the medication buprenorphine for a year, 75% stayed in treatment, 75% were totally abstinent, and no one died. So I think if we had another illness where there was an intervention that led to no one getting well and 20% of people dying in 1 year, we wouldn't still be offering it or paying for it or recommending it. And yet today across the country, people are going to seek out and go or be referred to detox for opioid use disorder, despite the fact that there's never been a single study to show that that's actually an effective intervention. Next slide. Again, this is a study I did where we looked at 6 different treatment pathways and looked at what the comparative effectiveness of what was associated with reduced overdose and reduced acute care utilization, and found that only methadone and buprenorphine are associated with a reduced overdose both at 90 days and 180 days. Next slide. So this wealth of evidence, again, now like more than half a century of data showing that medications are the cornerstone of treatment for opioid use disorder, led to the National Academy of Science, Engineering, and Medicine putting out this report last year saying that medication treatment is effective across all settings, and that withholding or failing to offer these medications in any treatment setting, including the criminal legal system, is denying appropriate medical treatment. And yet we continue to see that the majority of treatment setters, so addiction treatment settings across the country, don't offer all of these medications. Most healthcare settings don't offer all of these medications. Very few doctors are even able to prescribe these medications. And in the criminal legal system, it remains the norm that people are forcibly withdrawn when they're incarcerated. Next slide. And so this is sort of the conundrum. We're in the midst of this overdose crisis. We have treatments that we know save lives, and yet there continue to be barriers and access issues. So if you think about that graph I showed you, a dramatic increase in deaths from the early 2000s up through 2019, you would think that we would see a dramatic growth in volume of the types of treatments that save lives. And yet we've actually seen the opposite. We've seen that the change in methadone access has stayed exactly the same. And buprenorphine, this life-saving medication, actually the growth has decreased over time rather than increasing over time. Next slide. Across the country, there are vast medication treatment deserts. So we're actually pretty lucky in New York and Massachusetts and New England in terms of access compared to other parts of the country, where 50% of US counties don't have a single prescriber who can actually offer buprenorphine, this medication that we know saves lives, despite the fact that we're in the midst of this crisis. Next slide. Racism, we've touched on the impact in drug policy and pain management. It also deeply impacts access to effective treatment. So if we look at actual physician visits for a person with opioid use disorder, Black patients are much less likely to be offered this life-saving medication at a visit than white patients. And overall, buprenorphine prescriptions are much more likely to be received at visits for white patients compared to patients of any other race. Next slide. I think you guys have an upcoming talk by Dr. Hansen. This is work that she led, and I'm sure she'll talk more about this, about racism and how it plays out in treatment access. Both her work and others' work at the national level have shown that access to methadone and to buprenorphine varies tremendously by income, ethnicity, and the race of neighborhoods. So in New York, 2 neighborhoods that had high populations of Black and Latinx individuals had the least access to and growth in buprenorphine over time. And methadone has been preferentially offered to Black and Latinx individuals as opposed to buprenorphine, and the greater flexibility that comes with that. Next slide. This happens across the country in terms of Medicaid individuals too. So if we look at nationally, individuals residing in counties with a low poverty rate and a low percentage of Black or Latinx residents are significantly more likely to receive these evidence-based medications. So the neighborhoods that have greatest access, where participants are most likely to get life-saving treatment in the midst of this public health crisis, are white and affluent neighborhoods. Next slide. Even when we have access to these medications, the first thing is access. We need to make sure that there's access to life-saving therapy in the context of this crisis, but then we have to help people stay on treatment. Because again, this is a chronic illness, much like diabetes or HIV. This is not sort of a short-term acute episodic intervention. And yet we know that amongst those who are at highest risk of dying, treatment retention is really low. So this was a study in Massachusetts where a colleague of mine, Dr. Mark Rothschild, looked at people who'd survived a non-fatal overdose and found that in the year after they almost died from an overdose, only 11% received methadone and stayed on it for a median of 5 months. 17% received buprenorphine for a median of 4 months, and 6% received naltrexone, which is a third medication that's available for only 1 month. And yet, even so, despite this short duration of treatment and much shorter than we would recommend clinically, there was still a reduction in all-cause mortality with methadone and buprenorphine. So these medications do save lives, but we need to figure out how to help people stay in treatment longer. Next slide. We also know, again, that racism plays out in treatment retention and in ongoing treatment. So not just access, but also whether people are able to stay in care and what the quality of that care is. So this is the study that looked at why people discontinue buprenorphine early. So I told you that, you need to say, we want people to stay on it longer and that protects them from dying. And yet we know a lot of people prematurely discontinue. In this study, the biggest predictors of discontinuation were racism, so Black race, and a suboptimal dose, so being dosed at a lower dose than we know is effective. Next slide. And treatment retention, irrespective of if someone continues to use drugs, has benefits. So we want to be keeping people in care. We want to be wrapping our arms around people and making them feel welcome, as opposed to the current model in much of the addiction treatment world, where anyone who has any symptoms of ongoing use is actually kicked out of care, sort of the opposite of what we would do for other chronic health conditions. So if you have heart disease and you're admitted with a heart attack and you're in the hospital and then you have more chest pain, the cardiologist is not going to kick you out of the hospital because of your chest pain. But if you have opioid use disorder and you're admitted to the hospital because of a complication of your opioid use disorder and you use opioids in the hospital, in some hospitals across the country, you'll actually get kicked out of care for that. Or in some addiction treatment programs, if you have a positive toxicology test showing ongoing use, you'll be kicked out of care instead of retained in care and given more support. So really the opposite of how we think about other types of healthcare. And this is a study that showed that staying in treatment, regardless of whether people continue to use based on toxicology results, that people's quality of life went up significantly just by staying in care and continuing that ongoing support. Next slide. And so if we're thinking about how then do we shift not only increasing access, but then actually helping people stay in care, we need to critically appraise the structure and delivery of our care systems. Again, with patients with substance use disorder and people who use drugs, too often the instinct and historically has been to blame the person who's suffering, to blame the victim. They didn't come into care, they must be in denial, or they left prematurely and went out and used, it's their fault, they must not have been motivated, or they must not have been ready. Instead of saying, what's wrong with us that only 10% of people with a treatable and potentially fatal illness any year are getting treatment that we have available? Like, what does that say about the quality of our systems, or how welcoming they are, or how appealing they are? And why aren't we looking at what's wrong with the care we're offering instead of blaming the people that are not accessing that care? Qualitative work that has looked at sort of predictors of staying in treatment have identified some really key factors to think about when we think about that structure. So this is a study looking at what predicted people staying or falling out of methadone treatment. And one person said, you could only miss a certain number of appointments in a row to stay on methadone. And he came back the day after he reached that limit and they told him he was no longer eligible for treatment. In contrast, a person who was able to stay in care said that staff who worked with them, who were nice and caring and respectful, who offered support and encouragement, that those were important factors in sticking with treatment. And that person's quote was, "They showed me that there's a light at the end of the tunnel. There's hope. You hear that? There's hope." And that's something I think we often underestimate, is the power of holding that hope for our patients and feeling that hope for them and enhancing their self-efficacy. In one of our low threshold clinics, we call our bridge clinic, we have a journal where patients can just sort of jot notes down to the staff or leave messages. And one person who'd been in and out of the emergency room with overdoses and terrible complications related to injection drug use, the type of person that often gets labeled by the healthcare system as, a high utilizer or, some other negative term. He wrote in the journal, if you think it's hard to watch this, imagine what it feels like to live it. And yet too often, I think that ability to empathize, actually put ourselves in our patients' shoes for the healthcare system at large when it comes to people who use drugs, is just missing. Next slide. This is another study that looked at high threshold versus low threshold care. So I would define almost all of the addiction treatment system as being a high threshold system, meaning we make it really hard to get care. There are a lot of barriers that people have to overcome in order to access services. And in contrast, what we've tried to do here at MGH, where I work, and I think really is the model that needs to happen moving forward, is how do we instead design a system that's low threshold, where we make it easy for people to access resources. We make it easier for them to get well than to stay out and get sick, and really flip that model on its head. And if you think about the access barriers for someone who's actively injecting drugs, the study kind of identified four main barriers. So the first is the registration threshold. Even accessing care and staff is tough. You know, I'm an addiction medicine board certified doctor, and I have people all the time ask me how to get care for their loved one in various settings. And it's challenging for me to figure out how to access care. And I know a lot of people, and I've been in this space for a long time, and I have a degree. Imagine if you're someone who's actively struggling, who has housing instability and trauma, and has been treated terribly in healthcare systems, and is actively injecting drugs, and you have to figure out where to go. You have to call. You have to be polite to the staff on the phone. You probably have to wait on a waiting list or call back. Even if you make it through all those sort of hurdles and actually get an appointment, you have to show up on time. Again, you have to be nice to people in the waiting room. You have to get in and go through a whole intake process. Like, there are a lot of hurdles to access care. And you can imagine why that feels insurmountable, or frankly, like, why bother if that's what you have to go through to even get services in the first place. If you make it through those hurdles, you then have to be able to actually communicate your needs, and you have to trust the team that's taking care of you enough to be able to share those needs, which is a tall order. And then the last is this one. I love this efficiency threshold, which one staff member said, you know, what about that person who needs 1,000 cups of coffee before they're able to start speaking about their needs? The current treatment system, the way it's defined, is never going to meet the needs of that human being. So in contrast, low threshold care really tries to reduce those barriers or thresholds by having less stringent eligibility criteria, sort of a just say yes, just come, we want you here kind of approach, to try to broaden reach and then hopefully keep people engaged. Next slide. But at the core of that, to really change the treatment system, the reason why we have this model of high thresholds, very different, separate and unequal care for people with substance use disorder and people with drugs, is because of our stigmatized beliefs, our biases, our ideology as a country around what it means to use drugs and what it means to have addiction, particularly to non-sanctioned substances. This is one of my favorite papers by Walter Ling, who's a physician scientist out at UCLA, where he reflects on kind of the history of medication treatment for opioid use disorder. And he highlights the fact that the mere existence of these medications, the fact that they have been well studied and are, available, has not been enough to change care. And that's because we as a society continue to think that people with addiction should just get off drugs by strenuously hauling themselves up by their own bootstraps and to stay off no matter what. And for nearly a century, physicians and healthcare providers have also been indoctrinated by those societal attitudes, that these people have brought this upon themselves. And therefore, even though we're starting to talk about this as an illness or as a public health issue, our policies continue to reflect this attitude that people who use drugs and people with addiction, maybe they're sick, maybe they need help, but they're also sinning. They're also doing something bad, and therefore we should never help them too much. So that sort of ideology, I think, is the hardest thing to overcome. And we see that play out in all sorts of ways, both at the micro level with clinical encounters and the macro level when we think about systems and structures. Next slide. One subtle thing we can do to start to address that ideology is actually be very thoughtful about language. Language has tremendous power. I think we can all recognize examples of that. And in healthcare settings, it has really a lot of power. The words we use matter. There have been many studies showing that chart notes that use stigmatizing language versus neutral language directly impact the type of clinical care that physicians offer. When it comes to addiction, a colleague of mine took master's and PhD level clinicians and gave them a vignette where a person was described either as a person with a substance use disorder or as a substance abuser, which continues to be a very common term. And the clinician, highly trained, doctorate level clinicians, were more likely to recommend a punitive criminal legal intervention for the person described as a substance abuser, as opposed to the person described as a person with substance use disorder. So this is not just like a politically correct thing or an issue of semantics. It actually directly impacts care. So when we think about language, we want to use person first, sort of humanizing language that doesn't identify the person solely as their illness. We don't talk about the breast cancer in room 34. We shouldn't talk about the alcoholic, sort of labeling someone as only being their disease. So a person with a substance use disorder. And then not using terms like abuse, which literally means a willful act of misconduct, which implies that, the person is somehow doing something bad, that they're similar to a child abuser or someone who commits sexual abuse, these terrible willful acts of commission. And that even other terms like the term clean, which is frequently used and thought of as sort of a positive thing, actually is a really negative term. It implies that someone who's actively using drugs is dirty, right? The opposite of clean is dirty. And, a colleague of mine who's in long-term recovery was interviewing for a recovery-oriented job. And the interviewer asked him, how long have you been clean for? And his reply was, well, I've been bathing since I was born. So I've been clean my whole life, but I've been in recovery for 5 years, just as a reminder that what do we really mean with our words here? So really being thoughtful about the type of terminology that we use. Next slide. So when we think about these structures of care, at their core, it's no different than patient-centered care that we talk about with any other healthcare system or any other illness. Patient-centered care is defined as recognition of the biopsychosocial influences on health, as acknowledging the subjective health needs and experiences of the human being that we're serving. Again, it doesn't matter what my needs are, it matters what the person who I'm taking care of, what their needs are. That tries as much as we can to have shared power and decision making between patients and providers, and that promotes communication based on mutual respect and trust. So that's it. That's what we need to do in the addiction space too. And yet, unfortunately, much of the care models are the exact opposite of that, where patients aren't trusted, their word is not taken, they're often in a very punitive power dynamic with their care team or their providers, and where there's really no trust, let alone mutual trust and respect. Next slide. When we think about the ongoing impact of racism in the overdose crisis and strategies to develop community-informed and community-involved interventions to address the overdose crisis in Black communities, this is a wonderful report put out last year by the federal government with a lot of amazing colleagues who participated in that. And they came up with some really broad strategies. So first, thinking about and implementing a comprehensive and a holistic approach. So addiction is not just about the neuroreceptor. Yes, neurobiology is fascinating, but when we think about human beings and the context that they live in, what is it that they're recovering from and what are they recovering to, as a colleague of mine recently said, thinking about the broader context that people find themselves in. Involving the community, developing multi-sectoral diverse community partnerships, increasing culturally relevant public awareness campaigns. One person commented that campaigns are entirely whitewashed and make no sense in Black communities. Employing culturally specific engagement strategies. So the opposite of addiction is not abstinence. It really doesn't matter whether someone's still using drugs or not. What matters is how their life is. Are they connected to people? What is their, what's their quality of life and their functional status? And then really crucially, and can't sort of emphasize this enough, creating a culturally relevant and diverse workforce at all levels. So having not just trained Black peers, but Black supervisors, Black physicians, Black leaders, Black presidents of organizations is crucial as we think about these strategies. Next slide. When I talk to colleagues about caring for people who use substances, I often try to kind of ground them in thinking about how they would care for someone who didn't use substances, because I think the affect and emotion that gets tied in, again, because of all of that societal ideology and all of those biases that people have been exposed to, is so different than how we think about any other illness. And so if we can just pause and think, would we respond this way to a patient with another medical condition? So again, that example I gave you of the person with heart disease who has chest pain, who is symptomatic, would we really kick them out of care? Are there ways in which our approaches and policies are actually the thing that are causing harm? So this is certainly true writ large across the country. We think about our drug policy, which is far more harmful, I would argue, than most drugs, but also policies at the healthcare level. There's a lot of ways that we either design or implement policies that negatively impact people with substance use disorder in terms of involvement of police and security when people are coming in for care, the freedom and rights, for lack of a better term, that people have when they're in the hospital. So lots of hospitals won't let people use drugs leave the hospital for. They're kind of confined to their room as if they're in prison. There may be changes in the visitor policy in terms of who can come. They might have their belongings searched, which again, all of these are experiences that are much more common in the criminal legal system than what we would expect in the healthcare system for any other illness. And then probably most importantly, getting back to that patient-centered care model, how can we identify, acknowledge, and support the person's most pressing need? Not what we think as healthcare providers, but what that human being needs in that moment, and how can we acknowledge that and then try to meet it? Next slide. These sort of themes echo what people who use drugs themselves have identified. This is a qualitative study done of people who use drugs who have left the hospital prematurely, exploring reasons for that. And the most common reasons were many of the things we've already talked about. So, people not having their withdrawal or their pain treated. So one person said, we really need to promote hospital retention. If I hadn't been so sick from withdrawal, if they would have just listened to me, I would have stayed in the hospital. Increasing responsiveness to subjective health needs, again, identifying that human being's needs, not what we think. And this person suggests that the hospital should ask the person, do you need anything? Are you using anything? Heroin, it's an addictive drug. How do you expect me to stay if you're not treating my pain or my withdrawal? And then promoting cultural competency. So really providing teaching to the staff so that they understand about addictions. They are able to challenge their own biases or at least recognize those biases that they're bringing, and that they treat people with compassion and gentleness just like they would for any other condition. Next slide. That sort of patient-centered care checklist, I often like to think about the mantra that was popularized in the HIV/AIDS activism era of nothing about us without us. That as we're thinking about designing these systems of care, we really need to be involving affected individuals, people in recovery, but not just people in recovery, also people who actively use drugs and what they need and how they would design a system to meet their needs. Respecting the dignity, humanity, and autonomy of individuals, which again, respecting the autonomy of people who use drugs is sort of anathema of everything we've done in drug policy in this country. That our care is guided by science, but delivered with compassion, that we use that person first and accurate language, that humanizing and non-stigmatizing language, and that we do all of this with an anti-racist and equity framework. Next slide. And then the science guiding us piece is very clear. When we're talking about opioid use disorder, medication is the thing that saves lives. It's the most effective treatment we have. It's also the most negatively viewed treatment we have. There's so much stigma about the notion of using a drug to treat drug addiction, and a lot of misinformation out there. If we're going to design a system that actually reduces death and improves quality of life, we need immediate access to all types of medication, harm reduction resources integrated into all of our treatment, and we need to tailor that science-based treatment to the human being in front of us, not to have one-size-fits-all models. And then our focus should be on what's going to help people stay in care. If we shifted the entire frame so that our focus is on retention, I think that would go a long way in terms of some of these really harmful policies and structures. Next slide. From a systems-based checklist, just to sort of finish things out, I kind of think of these three main buckets. Prevention, which to me is where the thoughtful opioid prescribing falls in. Like, yes, we don't want to be giving people huge amounts of opioids for a dental extraction. We want to be thoughtful about how we're initiating opioids and prescribing them. And hopefully down the road, that will lead to prevention of new opioid use disorder, both from excess pills in the community and from exposure to someone who might be vulnerable. But the much more impactful and broad-reaching and harder work to do is really to address the risk factors for development of opioid use disorder. And this is not, drug education in schools. This is really building resiliency in young people and families and communities. It's addressing poverty and racism and social despair and isolation. Having families that are able to be together and stay together and eat dinner together. Those are things that actually prevent the onset of substance use disorder in young people. And then for people who do develop unhealthy use or problematic use, we want to identify it early, not wait until they show up in the hospital with a new diagnosis of HIV or after an overdose, but really to identify things when they first start running into trouble, when it's much easier to intervene. From a treatment standpoint, we talked about access to all types of medication, integration into all settings. It shouldn't matter if you go to your primary care doctor, your psychiatrist, your OBGYN, you should be able to start treatment wherever you are. And that treatment should be low threshold and welcoming and embracing. And then harm reduction, as I mentioned, interwoven throughout. But when we talk about harm reduction, we're really talking about naloxone, which is a medication that reverses overdose, syringe service programs, and safer smoking programs to reduce the infectious and other complications for people actively using. Supervised consumption spaces, which are authorized in many other countries across the world. There are only underground supervised consumption sites in the US currently. And then a safe supply, that the poison drug supply is really what is leading to such unpredictability and such death. Next slide. And then just to end with this graphic, this is the work that we've embarked on here at MGH. We launched in 2014 with the sort of simple goal of trying to integrate effective treatment across all of our care settings so that regardless of where people show up, again, their primary care doctor, the emergency room, inpatient, they would have access to a team, and everything we do are interprofessional teams with mental health clinicians, doctors, social workers, peers, we call them recovery coaches here, but people with lived experience, and a whole range of kind of a team-based model, nurses that can meet people where they are, support them, provide care, and follow them over time. Next slide. So that is all I have, and I hopefully we have some time for questions, and thank you all so much for your attention.
Thank you, Dr. Wakeman. That was amazing. You've given us a lot to think about. And in some ways, most importantly, a map in which to help change the way we're thinking, because I mean, ever since Irving Goffman taught us about the notion of stigma in medicine, we still continue not always to recognize our own biases, our own frameworks that we're bringing into. And as you point out, particularly towards the end of your talk, those frameworks are actually getting in the way of our ability to treat patients. So we do have a lot of questions.
Great.
And but I know we are running out of time. So I do want to say right before I get to the questions to remind you that as Dr. Wakeman mentioned, Dr. Helena Hansen, an anthropologist and physician from NYU, will be speaking as part of this series on November 12th, 6:30 to 7:45, moderated by Lydia Dugdale from the Center for Medical Ethics here at CUMC. And I also wanted to give a quick thank you, because I didn't earlier, to Bob Klitzman, from my own master's program, Masters of Bioethics. And if you have interest in these topics, to please check out the website for the Master of Bioethics here at Columbia. And now I wanted to get to some of our great questions. So first, we had a question from one of actually our students asking how you thought the media might have media coverage of the opioid crisis, overdose crisis, might have affected stigmas and perceptions of the affected populations, how it's often viewed as a white problem, leading to lack of resources in Black and other people of color, their communities. What do you think the media played a role in this?
Absolutely. I mean, I think the media, there's some amazing journalists out there. And for folks on Twitter, there's some awesome folks on Twitter that you can follow. A group of us that was a sort of broad coalition of journalists, lawyers, policy people, people with lived experience, doctors, researchers came together and formed a group called Changing the Narrative. And we have a web page that has some of the common tropes and myths that are perpetuated in the media about the overdose crisis, and kind of challenges those myths. And then also has a whole list of us, myself, and many, many other people who are happy to be contacted. I think one of the challenges, again, gets to the fact that there's so little accurate education across society about addiction and about drug use. And so unlike other elements of journalism where often science reporters are covering science issues, in many cases, the reporters covering the overdose crisis are like on a crime beat, or they don't necessarily know anything about the topic. And so they're not coming to it from the same sort of informed background that some the journalists who really live in this space and the journalists reporting on other topics might be coming from. Too often the articles that are written are sort of overdose crisis porn, for lack of a better term. It's like the devastation and despair, as opposed to the message of hope that, you know, there's 24 million people in this country living in long-term recovery. We don't hear about those folks. We hear about like the terrible stories of people dying or people doing awful things. The rare cases when we hear a hopeful story, it is always a white person, and it's always the sort of whitewashed narrative of the innocent white victim, some young student who got iatrogenically exposed to opioids by, you know, an evil doctor and pharma company, and then unwittingly developed addiction and suffered some consequence, which it's rarely that simple. And that narrative actually reinforces all of the stigma against then bad people who use drugs who aren't that sort of that pathway. It's also rarely a true pathway if you actually dig into the details. The other problem is there's often false equivalence in terms of who's given weight in articles. So it's sort of like, on the one hand, here's an expert who's dedicated their entire career to studying and knowing about addiction. On the other hand, here's a probation officer whose personal opinions are that, you know, X, Y, and Z, as if those two things are equivalent, where we don't see that same sort of false equivalence in reporting on other topics. And there's a strong tendency to both involve and validate sort of judges and law enforcement officials' perspectives on drug use and addiction, which again reinforces the idea that this is a behavioral or a criminal legal issue instead of a health issue. But yeah, check out Changing the Narrative. There's a million things on there that are too much to summarize right now, but it's a great, hopefully a great resource and website.
We have another question. There's a couple different treatment options, contingency management, which there was an article in the New York Times this week about safe injection centers. And then someone's also asking about 12-step programs like Alcoholics Anonymous or Narcotics Anonymous. I know that some of them, you know, sort of speak to all the stigma and preconceived notions that we have. So we immediately are against, you know, some of these ideas, and others maybe are they addressing some of the things that you listed as really effective, which is hope and a low threshold approach. So can you comment on some of these other treatment modalities?
Yeah, absolutely. So contingency management is giving positive rewards for sort of healthy behaviors, or so usually it's focused around engagement and treatment, like showing up for your appointment, or sometimes linked to toxicology, like not using the substance that you're trying not to use. And it's very, very effective. And that's human behavior, right? We all respond better to positive rewards. Unfortunately, with addiction, we've often done the opposite. We try to punish people for bad behavior. That's what our entire criminal legal system is based on, right? Or our child welfare system, like you're bad, I'm going to take your kids away or send you to prison, which doesn't work and worsens despair and isolation. But positive rewards really work. And they work for, any of you who have engaged in like an employee sponsored, you go to the gym, you save some money in your health savings account, or there's lots of ways that we operationalize this for other conditions. And so I think this notion somehow that giving positive rewards to people who use drugs is a crazy idea, just gets at how deep the stigma is, but the evidence is really there. It's most effective at engaging people in care. So you then want the care to be there that people are engaging in. And there's also ways to give positive contingencies that aren't financial. So we often say in our low threshold clinic that, kindness is a positive contingency that's free. So welcoming someone with a cup of coffee and telling them they can charge their phone and do they need some warm clothes or a shower, like those are positive rewards for showing up in treatment. And yet too often, again, treatment systems are like really unwelcoming. They're rude, they're mean to people, they don't welcome people in. And so there's less incentive for people to go there. So super important intervention that can be incorporated. Supervised consumption sites are supervised settings where people can use drugs. Again, I mentioned that no one should die from an overdose. We have an antidote to overdose that immediately reverses the effects, much like an EpiPen reverses the effects of anaphylaxis, or if someone's on insulin, giving them glucose reverses the effects of too much insulin. And yet the reason that so many people, 72,000 people died last year, is that they're using an unsupervised and unsafe setting. So a supervised site is a safe space where people can use. We know that they reduce mortality. There's never been a death in one. So although there have been overdoses on site, because there are people there to respond, no one has ever died, unlike the 72,000 people who died in unsupervised settings last year. So they may sound crazy, but they're actually incredibly evidence-based. And I think the important thing in that discussion is it's not supervised consumption sites or no drug use. It's supervised, safe spaces where people can use, or unsupervised use in public bathrooms and in alleyways and alone, which lead to death and infection and bad things happening to them. So, a bar is a supervised consumption site. It's a place where people drink in a supervised setting. So we do that for many other contexts. We just think of it as very different when it comes to drug use. And then lastly, mutual help, which 12-step is a type of that. I continue to consider that's sort of one type of recovery support. So being supported by other people who have lived experience like you. Certainly AA is the most well-known of that and the most widely available. The data on AA is quite clear that for people who it works for and who continue to go, they do better. So like if you go, the more you go, the better you do. But for people who are required to go, it's not, it doesn't improve their outcomes. So I think the most important thing is, can you find some sort of community support, resource, identity, purpose that helps support you in that process of recovery? Drugs serve a powerful role. There are a lot of positive things that come from using drugs. And when people get to the point where they're ready to stop using drugs because negative things have happened to them, it doesn't mean those positive pieces have gone away. And so simply removing the drugs is not enough. You need to figure out how do you help that person fill up their life? What are the other pieces that are gonna take the place of that? And having a community, a sense of belonging and support is a really important one. Just one last point, one challenge with AA and Narcotics Anonymous is some groups are very negative about medication treatment. And so that's something that's come out a lot in research and also just anecdotally with patients, is it can be a real deterrent to be on these medications that we know are the most effective treatment, because they're often, depending on the group, they may be treated poorly or told that they're not really sober, or that there's some problem with being on that medication.
So I think we may have time for one more. We don't really, but I'll just.
I'm happy to say, but I know people may have to go.
People have to go, but so this question is: assumed in the slides that any statistical differences in groups defined by race is automatically correlated to racism. Is it possible to have a difference in patient outcome that is not racist, i.e., could there be confounding variables that aren't considered in the study, like socioeconomic status, region or place of living, etc.?
Sure, yeah, and that depends on the study. I think a lot of those studies do control for other confounders, and regardless, the reason, I would argue that the reason there's economic differences between Black Americans and white Americans is racism. So I guess it depends a little bit on how you define racism. I think I don't have another explanation for why a Black patient and a white patient with the same insurance going to see a physician with the same disease, one is more likely to be offered a life-saving medication than the other. Like, to me, that seems like it's probably racism. It could be structural racism. It could be personally mediated racism. There's lots of different types of racism, obviously, but I think we have to be willing to name it as racism, particularly right now, and in order to address it. So yes, confounders happen. Yes, we have to be thoughtful in our design, but I think we also can't be controlling for race in our studies. I think that leads to really not identifying racism or talking about it.
And I have one last question for
Yeah.
you. Okay, you are now queen of the country, and you can tell medical schools what to teach medical students, because clearly I think of my own medical training and I got very little in the way of, I certainly didn't know about, how to prescribe methadone or buprenorphine, and even the fact that you have to do extra education. I can almost see it, only in that we get so little education in medical school about these topics, something that's so prevalent in our society.
Yeah.
What would you recommend? What would you tell medical schools to teach?
Yeah, I think they should approach this the same way they approach learning about other conditions, which first is to give it space and priority in the curriculum. This is a public health crisis that's killing, 72,000 people a year. We should be getting more than a 1 hour lecture on it in our medical training. So I think that at the undergraduate level means, didactic classroom-based learning. Importantly, it means faculty role modeling and mentoring. I mean, that's how I got into this space, was I had an amazing mentor who did this work, and I otherwise never would have even known that addiction medicine is a thing, but I got to work with him and see the work and see how incredibly rewarding it is. I think from the start, students have to be exposed to the full arc of people's experience who use drugs and who have addiction, not just the person in crisis in the hospital, because I think often what they see is the person in the emergency room or the hospital who's in crisis. They get exposed to the hidden curriculum of the negative attitudes of their residents and their supervising physicians towards that person, and they never see that same human being then parenting and the humanity of that person. They only have that sort of image in their mind that addiction is this recalcitrant, untreatable condition, and that it's very frustrating. And I think if you go into a profession where you want to help people and you feel like you have nothing to do to help, sometimes the instinct is then to turn away or to blame the person or to withdraw from it. I think we see that too often. So they need that experiential learning, but they need it with faculty who can be role models. And then I do think that message of hope throughout, a really powerful tool in teaching for me has been to bring back patients who share their story and they share their narrative, and that, that sort of that saying, it's hard to hate up close. Like when you actually get to know that human being and hear about their journey and get to share some of that hope with them, that's incredibly inspiring. I will say, as a doctor, like I'm also a primary care doctor and I do hospital medicine. Treating addiction is the single most rewarding thing I do in medical practice. It's one of the few areas of medicine where it truly feels like we can make this dramatic difference with patients and be a part of that change in their lives. And I don't think that students and residents get that message in their training. So if we could even just communicate that sense of kind of this is something to feel inspired about, I think that would go a long way.
Someone does have a technical question here.
Sure.
And does methadone bind the same receptors as heroin and oxy? Is there a strong dependency to not only the medicine, but having to receive the daily dose at the clinic?
Yeah, so great question. So this gets to the difference between physical dependence and addiction. So addiction is defined as compulsively using a substance despite bad things happening to you. Dependence is physically needing a substance, or you get a withdrawal syndrome, or you get sick if you stop it. So anyone in the audience who takes a certain type of antidepressant or insulin for their diabetes or thyroid medicine for an underactive thyroid, you are dependent on your medication. If you were to stop taking it suddenly, you would get sick, but you're not addicted to your medication. You're not compulsively using it despite it causing problems at work for you or causing problems in your relationships. That distinction is incredibly important because, first of all, if dependence equals addiction, it implies any patient with chronic pain, for example, is addicted to opioids if they're being treated with opioids, or any person treated for anxiety is addicted to their meds. But it's also important because the two medications that work best bind to those same receptors. They bind to the opioid receptor, but they cause, the way that they work is they have sort of a slow onset of action and a very sort of long, flat half-life. And so the idea is that you take someone who lives in this constant bouncing between feeling normal and then feeling sick and in withdrawal and needing to seek relief to feel normal again, and you give them a medication that allows them to function normally. So it's very similar to, again, how we treat diabetes or thyroid disease, where you take a chemically similar molecule that acts at the very same receptor in your body that missing substance does, but you take it in a form that evens you out and allows you to feel totally normal. So that's what methadone and buprenorphine do. They're essentially like long-acting insulin. insulin for someone with type 1 diabetes, but for opioid use disorder.
And are the underlying mental health illnesses actually being resolved when being on such a strong medicine like methadone? This is also from the question box.
Yeah, so co-occurring mental health and mental illness is quite common depending on what sample you look at. It can be anywhere from like 25% up to 50% or more. But addiction is not sort of purely a manifestation of untreated mental illness. I think that's a common misconception that if you're addicted to heroin, you must be mentally ill, you must be depressed or anxious. Not everyone. Some people are. Some people become depressed because of how we treat people who use drugs. And some people, of course, co-occurring pre-existing psychiatric illness is a risk factor for developing substance use disorder. But those two things are not always one and the same. So methadone treats the opioid use disorder. It helps your life get better. It helps you feel better. So in those ways, it can have other positive mental health benefits. But if you also have, let's say, bipolar disorder or schizophrenia, you still need treatment for those conditions as well. So unfortunately, in much of psychiatry, historically, there'd been an approach that people have to like stop using drugs before they get their psychiatric care. I think we know now, like you need both whenever you're ready for it. If you have, terrible trauma, it's going to be really hard to stop using drugs because your trauma is going to get worse when you stop using drugs. And so we need to make sure someone's getting good psychiatric care at the same time that they're getting methadone or buprenorphine or whatever they need for their opioid use disorder.
Thank you. Thank you so much. Thank you for going over. Thank you everyone for staying. And this was an amazing an amazing hour with you. And I think we've all learned a lot. So we're very grateful.
Thank you. Feel free to reach out if people have other questions. And thanks for having me today.
All right.